Apparently, it's a real thing.
Yeah.
Now, in addition, of course, to medications, injections that are steroid injections, right? That's what.
Yeah, they can utilize different types of steroids, or they could be local anesthetic depending on what we're doing. There's also radio frequency ablations where we're selectively destroying nerves that are telling the brain that a certain part of the spine is painful, and a lot of people get scared when they hear that it's a 5-minute procedure. It
Right.
can, you know, for chronic pain. Chronic pain is not helpful, right? If you step on a nail, you have to feel that.
Right.
But once you get off the nail, you don't need your foot to hurt for the next 2 years.
Welcome to Brain Buzz, where we delve into the fascinating world of neurosciences and brain health. I'm your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen.
Today, we're going to talk about a very important issue in the neurosciences, and that is pain. Pain is very prevalent. It's everywhere. It's part of our lives. It's what makes us human. And we have a great guest to help us navigate the world of pain, hopefully painlessly. And this is Dr. Eric Fanaee. Eric, welcome.
Thank you for having me.
So, Dr. Fanaee, Eric, we know each other for about almost 10 years now, since I came to Long Island. You were here before me,
Yes.
practicing in managing pain and taking care of these most challenging patients. And of course, this is a field that is, I believe, squarely in the field of neurosciences, since all the pain components, of course, are navigated and realized through the nervous system. But to get to become a pain doctor or somebody that deals with pain, you can come from multiple different pathways, not necessarily always from a traditionally neurological field. But before we get into that, tell us a little bit about yourself. Who are you? What are you doing here? And
Yeah.
what got you?
Well, first of all, thank you guys for having me. I really appreciate being here. So I'm Dr. Eric Fanaee. I'm originally from Chicago, and I always wanted to be a family doctor. I always wanted to be a family physician or an internal medicine physician.
Failed.
You see, exactly. You see patients every so often, and you kind of see them grow throughout their lives. When I got to medical school, I became interested in anesthesiology as a field.
Okay.
I kind of stumbled into pain management kind of by accident.
Okay.
At the time that I was going through school, and this was like 20 years ago now, anesthesiology was very popular. And so during your 4th year of medical school, you do your electives in different specialties, and anesthesiology was full. So I went to the second best thing, which was interventional pain management, which at the time was under the branch of anesthesiology, and I fell in love with it. I had a really good mentor. His name was Dr. Charles Laredo, and I really got to see how different techniques such as interventions, medications, and other modalities can sort of be creatively used and modified to really help people and really, realize reduction of pain and really make an impact in people's lives. So after that month, I realized, okay, I'm still going to do anesthesiology, but I'm definitely going to do another year of fellowship for interventional pain management.
And that's the point. Anesthesia was one of those fields that leads into pain management. How can you get to pain management through other paths?
Yeah, and that's an excellent question. So traditionally, anesthesiology has been the primary way to arrive at a fellowship of pain management. However, it has also been open to other fields, traditionally physical medicine and rehabilitation,
Okay.
PM&R. Lately, the field has opened up to internal medicine,
Okay.
emergency medicine, neurology, even family medicine.
Wow.
So pretty much any neurology-related specialty, let's say,
Okay.
can ultimately, elect to do additional training to become an interventional pain specialist.
Got it. And of course, pain is one of those fields that garners a lot of attention in the public eye, and in recent years, maybe one of those kind of controversial topics that I think became an important field, of course, since pain became another vital sign, right? And
Yeah.
since that moment, we always have been striving to get pain to, at least in the United States, to a level of 0, which came with, of course, going to the other extreme, over medication, overuse of opioids, and then the backlash to the other end. And you've seen a lot of that pendulum swing from one end to the other. How did you navigate this positive publicity? Here we are saving people, getting pain to 0, to pain doctors are the devil. They're using too many drugs. And where are we today? How has that been for you?
Yeah, so I've been in practice for 12 years. And when I first was going through medical school and the beginning of residency, the pendulum was the other way, the way that you described, with pain as the 5th vital sign,
Right.
trying to drive the pain down to 0, and then having all these issues with side effects and addiction, and really kind of destroying people's lives in the long run. Over the course of my experience in practice, the pendulum has kind of swung the other way,
Right.
where these types of medications such as opioids, oxycodone, morphine, Dilaudid, they have a use. They have uses for certain types of conditions, but it may not necessarily be the first tool that you would reach for when you're seeing a patient with neck pain or back pain. And so it becomes a tool, but maybe becomes a second or third line tool in most conditions. And there's so many other treatments that we can offer for patients who are looking for pain relief, but not
Right.
necessarily being on these medications.
And I think that's spot on, of course. And I always tell my patients, if of course I'm sending them to you, that don't worry, he's not into medicating you as a
Right.
means of getting your pain go away. And largely, of course, you deal a lot with neck and back and thoracic spine pain. And a lot of this pain is inflammatory in nature, right? So kind of
Absolutely.
opioids wouldn't really fit that. Talk to us a little bit about that.
No, you're absolutely right. So a lot of spine pain is inflammatory in nature, and inflammation is basically a chemical reaction, usually in response to injury of the body. So you're absolutely right. Opioids do not directly treat inflammation. Inflammation leads to pain. So opioids may treat the pain, but they're not necessarily addressing the root cause of the pain. So a lot of times in my field, in your field, and others, we really try to diagnose and get to the root cause of why somebody's in pain, which particular structure is actually causing the pain. Like,
Mhm.
for example, if there's back pain, there's multiple different structures in the spine which can cause the same pain picture.
Right.
And so we're focused on really trying to diagnose and determine and treat that source so that they don't have to take opioid
Gotcha.
painkillers.
Do you think the current level of regulation, some people would say maybe overregulation of opioids, is appropriate, or is there, or is it too much?
That's an excellent question, and the answer is I don't think I know.
I'm trying to get you in trouble.
Yes, of course, as always. But you need to have some kind of regulation, because you have to kind of make sure that people are doing the right thing and not overprescribing. But on the other hand, there are certain patients that really can benefit from these medications. So it's a matter of sort of, you really have to individualize the care. And sometimes guidelines are general guidelines for populations of people, but as physicians, we're treating individuals, and so it is important to have some guidelines. But on the other hand, you really got to look at the patient and really determine what the best course of action is for them.
Right, because statistics, like I always say, statistics are statistics, but if it's you, it's 100%. So
Of course.
that individual patient might benefit from like you always do, a more personalized strategy when it comes to pain. And so, of course, medications is one way to deal with pain, and there's not just opioids. There's other medications that
Oh, yeah.
traditionally address nerve type of pain, and then of course there is interventional approaches to pain, which is I think what occupies probably 90% of your time. And talk to us a little bit about injections. Of course there's different types of injections, but what do injections do in regards to neck and back pain?
Yeah. So injections or interventional pain management, there's hundreds of different ways to do them, hundreds of different types of injections, and they actually have multiple roles. First, they have a role in diagnosing the source of the pain. The example I was giving before, let's say somebody has back pain and it feels like it's pain across the back. That feeling of pain across the back can come from multiple different parts of the spine.
Mm-hmm.
And sometimes we'll have a good history, a good physical exam, a good MRI, and the MRI shows multiple different things that could be the problem.
Right.
So sometimes we'll do a diagnostic injection in one part of the hole to see if that part is causing the pain or not. If we determine that that part of the pain is the causal agent, we can then further treat that particular issue. On the other hand, if we do an injection in that area and it doesn't help, okay, we've got to look to the other parts of the spine.
Right.
And also, it's diagnosis. So
and that part of diagnosis, of course, is important for you to pinpoint where it's coming from. It's also important from somebody like a surgeon,
absolutely,
where if the eventually injections and conservative things fail, and they are considering surgery, targeting the appropriate level or the appropriate pathology is key in a happy patient, and so that's very important for us also.
Absolutely, I think it's critical for surgeons who want to do sort of the minimally invasive thing possible, surgeons such as yourself, when the MRI shows multiple different levels, rather than if the patient needs surgery, subjecting them to a multi-level surgery. If I can help pinpoint which area is the problem, you're able to offer them something that's not addressing everything, but addressing only the part that's causing their pain and leaving everything else that's not really causing the pain alone, and they get a better outcome because of that.
Right. And maybe we're getting too far ahead of ourselves, but here is an out-of-the-box question. What is pain? And why do we need to be in pain as humans?
That's an excellent question. And of course, it's something I've thought about throughout all my career.
Naturally.
So pain is very important. So, what is pain and why do we have it? If you look at the textbook will say pain is an unpleasant sensory stimulus, which means it's a feeling that also has an emotional component, which is a mental feeling. And basically, it works to protect us. So I give an analogy of, let's say that you're at home and you're barefoot and you're walking around. You go outside and you step on a nail.
Mm-hmm.
Or let's say you're coming downstairs and you step on your kid's Lego. Well,
that's misery.
That's worse than the nail.
Yeah, it's probably worse than the nail. I mean, those Legos are...
Yeah, tell us about it.
Yeah.
So that's very, very painful, and maybe there's profanity associated with stepping on that Lego.
Definitely.
But why does it hurt so much, and why is it so important? So pain is a representation of an injury to the body. So you need a way to know that something that you're doing is harmful to the body. So we have this system of pain that comes into play. And why is it so bad? Like, why is pain so bad? Because if you step on a nail or a Lego and you're thinking about lunch, or you're thinking about what you're going to do when you get home, or you've got patients on your mind you're thinking about, you need a very, very strong signal that tells you, hey, buddy, whatever you're thinking about, drop it and step off this nail. So that's the reason why pain is so strong and the reason why we have it. Very, very important to prevent injury. Now, that's acute pain, and of course, chronic pain is...
Right, a little bit of a different story. Now, people have seen on TV shows and otherwise, kind of in the popular culture, and they've heard about folks that are born with insensitivity to pain. They don't feel pain. Is that real, or is this made up?
It's definitely real, and thinking about that, you would think like, wow, that would be really nice, not to have to feel back pain or neck pain or if you break a bone. That sounds kind of nice, right? I mean, not having to feel pain in your life, but actually, those people have a very low survival rate. It actually has to do with a mutation in one of their receptors, which is one of these things that helps your nervous system talk to each other. So their pain transmission system is not functioning properly. They don't feel pain. And as I was saying before, if those people step on a nail, they may not know to get off that nail. They might stay on that nail or step on more nails or not put shoes on. And so they can accumulate injuries, and they really have a low survival rate.
Wow. So, that's fascinating.
There was a Bond villain. I forget what movie it was.
Yeah.
Where that was his big, like, almost superpower, is that he couldn't feel pain. So in the fight, whatever you did to him, it didn't matter.
Right, but the flip side.
I mean, he died at the end.
I think he died at the end because he wasn't.
Because he was the villain.
Because he was, of course.
Well, I think there was like radiation involved and stuff, so it was far out there.
Well, no, apparently it's a real thing.
Yeah.
Now, in addition, of course, to medications, injections that are steroid injections, right? That's what.
Yeah, they can utilize different types of steroids, or they could be local anesthetic depending on what we're doing. There's also radiofrequency ablations where we're selectively destroying nerves that are telling the brain that a certain part of the spine is painful, and a lot of people get scared when they hear that it's a 5-minute procedure. It
Right.
can, you know, for chronic pain, chronic pain is not helpful, right? You know, if you step on a nail, you have to feel that.
Right.
But once you get off the nail, you don't need your foot to hurt for the next 2 years.
Right.
So that's chronic pain. So that's kind of what we treat with that.
What are some common causes of chronic pain that our patients might deal with?
So chronic pain can result from a lot of different issues. There's hundreds of different possibilities. But most commonly, chronic pain comes from degeneration of certain parts of the body, degeneration of joints. In the spine, the intervertebral disc, which is the cushioning between vertebrae, can become chronically degenerated and arthritic, and that can become a source of pain that's always going on. Degeneration of the facet joints, which are in the back part of the spine, can also cause pain. Then you have things like CRPS, where the nervous system becomes hyperactive. That can become a source of chronic pain.
What is CRPS? I actually thank you for mentioning it, because it's something that we see often and very unrecognized in the general population. People keep getting surgeries for pain, not recognizing that the solution is not surgery. What is CRPS?
Yeah, so CRPS is essentially the nervous system itself. Remember, the nervous system is the part of the body that transmits pain to the brain. And so we do have a part of our nervous system called the autonomic nervous system. So this part of the nervous system is the part of the nervous system that we don't control. So
Right.
things like breathing, digestion, all kinds of things you're not thinking about. So that nervous system is also involved in other functions as well. So CRPS often happens in response to an injury, particularly of a hand or a leg or really any part of the body. And a lot of times there may be a genetic susceptibility to developing CRPS. And essentially it's the nervous system becoming hyperexcitable and sort of functioning abnormally. And it can be treated, and it's been studied, and we don't really know why it happens, but we do know a lot about it and how to treat it.
What are some treatments?
So CRPS, we do want to be pretty aggressive with treatment. I think this is important for the
$1 million
viewers to-
question, by the way.
It's a great question, and it's been something that's, even when I was in medical school, it was called RSD then, but there's a lot of different treatments for it. First line is nerve pain medications such as gabapentin or Lyrica, membrane stabilizers, tricyclic antidepressants, and there's certain types of injections that we can do, sympathetic blocks, which are 5-minute injections to interrupt the autonomic nervous system. Then there's also spinal cord stimulator. But most importantly, physical therapy is a key part of treating CRPS. A lot of times physical therapy can be very painful for patients to get through, and that's where somebody like I would get involved to sort of help them with medications, injections, and things like that to be more effective in physical
So you
therapy.
kind of bridge that gap so they can do the physical therapy.
Yeah, exactly.
Makes sense.
So again, medications, injections, and then what else? What else do you do?
So we do things like spinal cord stimulators.
Talk to me a little bit about that, because I think
yeah.
it's fascinating how spinal cord stimulators trick the brain.
Exactly. There's so many ways to explain how a spinal cord stimulator works. I think, one technique that I find that's helpful for patients is, let's say that you're walking around and you bump your knee on the corner of a cabinet. So if you do that, it really hurts, right?
Mm-hmm.
Really, really hurts. So we instinctively rub the knee, and it feels a little bit better. So the question is, why does that feel better? So what's actually happening is, when you're rubbing an area that's painful, you're activating touch receptors in the knee that flow into the spinal cord, and it kind of drowns out the pain signal. So a spinal cord stimulator does that. It basically intercepts the signal, the pain signal that's coming from the body, and it intercepts the signal before it can reach the brain, so it can really prevent that pain from being perceived. And that's more or less how it works. Then there's the gate
100%.
theory and other theories.
Well, yeah, the gate theory, but it works similarly to a TENS unit, right? But it's kind of an internal
Yes, it's kind of
version of that.
Yeah, a TENS unit is, of course, an external application of electrical pulses specifically to muscles and perhaps deeper structures. a spinal cord stimulator does the same thing, but it's a little bit deeper.
Right.
So it's more specific for nervous structures. It's really good for treating nerve pain.
Right. And a lot of patients don't want to commit, of course, to a device and a surgery.
Yeah.
But my understanding is you guys do a trial first where you try to see whether, if you are to place a stimulator, is it going to be effective for the treatment of pain? And I think you do that first.
Yes, absolutely. So you're absolutely right. So a spinal cord stimulator can be thought of as like a pacemaker for the spine. And yes, it's a medical device, and maybe people have some little anxiety about having that implanted. And we don't want to implant any device if it's not really going to help the patient. So we do a spinal cord stimulator trial. We place 2 leads in the spine. That procedure takes 20 minutes. And patients can actually test drive the device for about a week.
Mm-hmm.
And they can really determine if it's helping them 100%, 80%, 50%, or not really. And, if it's really helping them a lot and they're able to function and play with their kids and walk, that's something that we would look to implant later on.
Wow. And what other implants do you do as part of your specialty? Of course, I've heard about the Intracept device and other. So what else do you use to address pain in the back?
Excellent question. So Intracept is kind of a newer procedure, although it's not that new now. It's about 5-10 years old.
Mm-hmm.
So Intracept it's actually not an implanted device. It's actually a type of a ablation procedure. So in the vertebral bodies, which are the bones of the spine, a lot of times there can be degeneration and inflammation within those bones. And that's a very, very deep type of back pain that's usually worse with sitting, in the car, getting out of the car, getting out of the bed. Now we have a way of actually getting in there and using a needle to kill what we call the basivertebral nerve selectively,
Okay.
leaving behind all the other nerves that you need to move your legs and things like that. So it can be very effective for that type of pain.
Right. And anything else in terms of interventions that you do that I didn't cover?
There's joint injections, there's
Okay.
PRP, there's intrathecal pumps, and there's all kinds of nerve. I mean, there's literally hundreds of different types of injections, but I think we hit the most
Those are the
common
basic ones, right? No, I mean, it's a fascinating field because it's so technologically advanced, and I think underappreciated how technologically advanced it is. And medications are 10% of what they do, and 90% of what they do is intervening to address pain.
Exactly.
And so when you're dealing with chronic pain, which I think is, of course, the holy grail of pain management, also probably the most challenging and no pun intended, the most painful part is to deal with chronic pain.
Right.
Is it something that you deal with by yourself, or is it a multidisciplinary approach? How do you handle chronic? And I assume chronic pain is the majority of what you handle anyway.
Yeah, absolutely. So just for the listeners, chronic pain is pain lasting at least 3 months, and most definitions say longer than 6 months. So chronic pain is just a long duration of pain that just kind of goes on and on and on. Yes, chronic pain is a little bit more difficult to treat because it could become sort of part of somebody's life. And so typically we like to utilize a multimodal approach with, utilizing physical therapists, acupuncturists. If a patient has a chiropractor, they like things like that. Imaging modalities, and of course interventions to really try to get as much relief as we can. And a lot of times you have to get a little bit creative when it comes to an individual in designing a plan for them. But to answer your question, yes, a multimodal approach is the gold standard. And
Yeah.
you could even utilize pain psychologists, cognitive behavioral therapy. There's all kinds of different things that we utilize for that.
And tell me a little bit about the most challenging patients, right? Patients with mental disability or elderly folks with dementia possibly that are experiencing pain and they cannot necessarily fully express, the quality of the pain, the location, the response to your treatment, frankly. How do you handle those situations? I would imagine that's not easy.
It's not easy, but a lot of times these patients will have family members that are accustomed to the patient's normal daily routine, and they can perhaps detect when there's a change. And that can give you some idea as to whether we think the patient's in pain or not. But it's challenging. It does require time. It does require a lot of talking with the caregivers and the families, and it can be challenging. But we see these patients.
All the
We can
time.
treat these patients, and a lot of times we have to really put our thinking caps on as to what is causing the pain, and that's with all patients too. But we see these patients, we treat them, and we do our best to do as best as we can with them.
And yeah, definitely not an easy thing to do. Tell me a little bit about. I think a lot of our listeners want to know about the use of cannabis in terms of controlling chronic pain. Right? A lot of people would self-medicate in an
Yes,
effort
of
to
course.
control. But I know that there's medical programs, and I'm sure you guys are running one where you utilize cannabis to treat pain. How does that work? Is it effective? And where do you think that it fits in the spectrum of treating pain?
Yeah, so there's interesting fact. We actually have, I'll call them marijuana receptors in the brain. They're cannabinoid receptors. And so marijuana will act on those receptors, and sometimes that can treat nerve pain or muscle pain. And it can be effective in some patients. I think that it does have to be individualized because there could be some side effects or perhaps even cardiac effects in the wrong patient. So, if somebody's thinking about that, it's really best to talk with your doctor and make sure there's no comorbidities that would be dangerous. I do think that it's less dangerous than opioids in general, but it's definitely something that you should talk to a provider.
Is it a
about.
long-term solution?
It
Like
can
whereas
be.
opiates you would think would be more short-term because of side effects and stuff like that.
And the addictive nature of it.
Exactly.
Well, that's the thing.
And then so that's what people are looking to this for, like more of a sustainable treatment option.
Yeah, I think it's reasonable in the right patients, and it's not really going to be like a cure-all. Like it's probably not going to treat 100% of somebody's pain. If it helps 10% or 20%, and there's no side effects, and they're utilizing it safely, and it's not interacting with their other medications, they're not on opioids. It's a reasonable thing to think about. It can be habit forming. It may not be as addictive as opioids, but it can.
Is there a difference between, say, what you would get on the street versus what they would have medically available as well?
So I think when we're talking about this type of issue, the answer is probably, because when you're looking at medical marijuana, there are certain growers in the state, and everything's standardized. So if a patient is going to go that route, you know what you're getting. There's no additives. We have to worry about fentanyl and other additives that you might get on the street. So we never encourage patients to get things off the street.
I'm asking more for the people that are trying to self-medicate.
Yeah.
As opposed to going to the right channels and they think, I don't need to do this, I can handle it on my own.
Yeah, and I think the question is, why are they self-medicating? Like, have we really diagnosed the problem? What's, is there a back issue? Is there a neck issue? Is there something else we can treat so that maybe they don't have to take as much or don't have to take it at all?
For sure.
But definitely would not recommend, getting it off the street, because you never know what's in it. You never know what they're going to add to it.
Gotcha. So what does the future hold for pain management?
Yeah, that's an excellent question. There's new treatments coming out all the time. We talked about the genetic mutation of the people who don't feel pain. So they've actually been studied, and there is a new medication out that actually inactivates that. I can't remember if it inactivates or activates that one particular receptor in which they have the mutation.
Oh, wow.
And it's for acute pain. Currently, it's FDA approved for acute pain, 2-week use. There's all kinds of new injections and different ways of doing them and different ways of approaching them. And
what about artificial intelligence? Everybody's crazed up about AI. Yep. So what is the role of AI in pain management?
I think there's going to be a huge role of AI in pain management. It's very exciting. I think one of the problems that we have, whether it's a physician thing or even a pain management thing, is we never know ahead of time if an injection is definitely going to 100% work. We make our best decision based on the information we have and then use the information. We also don't know if there's going to be a side effect of a medication or what the proper dose is while they're waiting for an injection. So I think AI is going to be able to listen to the conversation, listen to the words that the patients are saying, perhaps even look at the hand gestures, perhaps even have a genetic like a genotype of the patient, and they can really assist with saying, hey, and even look at the MRI and kind of take everything together and really assist us in really getting it right the first time and getting them on the proper medication the first time until they can get their injection and get off. So,
Gotcha.
but who knows?
Do you see like Neuralink and things like that playing a bigger role overall?
I'm actually not sure.
Okay, because I know when we talk about Neuralink, a lot of times it's people that are paralyzed.
Yeah, I think that's more a mobility thing, but will it
Right.
become in the realm of functional neurosurgery and chronic pain? There's definitely utilities in stimulating centers of the brain, but I think we're
Or decrease in stimulation.
right, or but we stimulate centers to actually silence them. That's the interesting part about deep brain stimulation. You have Parkinson's. People are over their motion, and you're stimulating a center to block that motion. But that's definitely in its infancy. Maybe there's some utility in the future.
Of course.
Now, a common question we get from chronic pain patients is, what can I do in terms of course, go see pain management and work with a professional. But are there common, easy lifestyle? And probably the answer is no, but I feel like we should ask lifestyle modifications that they can do to decrease the level of pain.
Absolutely.
Diet, exercise, whatever it is.
Yeah, so absolutely weight loss can be helpful in decreasing pain. Exercise in general is good for pain. It can even be good for acute pain. So I always encourage patients to walk if they're able to, right? If they're able to walk safely, try to walk as much as you can. If you can't walk, let's think of something else you could do. Get outside, get some fresh air, get some sun appropriately. If they're smoking, if you can try to stop smoking. So none of these are easy to do. They're very difficult for patients, especially if they've been habits, but a lot of times patients can, if they realize they want to feel better, even losing 5 pounds or even just walking a block if they've only walked basically nothing.
Right.
Every little bit counts. And so these are easy things to get better sleep.
Okay, that's awesome.
Yeah.
So tell us a little bit. We're going to step back a little bit and talk about yourself again.
Oh, great.
What's your favorite and what's your least favorite part of the job, being a pain management doctor?
So my favorite part of the job is when I'm able to provide a significant amount of relief to a patient with an injection in a very short amount of time. So for example, somebody has an acute disc herniation, it's 10 out of 10 pain. Nerve pain is 10 out of 10. It's either on or off. There's nothing in between.
Right.
We do an epidural steroid injection, which is a 5-minute injection that we do under sedation, and they're 80% better. Now they can go to physical therapy. They can go to their chiropractor. That's my favorite part of the job.
Right.
I think the least favorite part of the job would be when you try everything, and maybe the patient's not better. Okay. That doesn't happen very often, but it does happen. And it sometimes feels like you failed, and usually those patients need surgery, and you guys do an excellent job taking care of them. But sometimes it feels like you kind of let them down. But the reality is a lot of these patients really do need surgery,
right?
And we try to avoid it, but sometimes it's inevitable.
Do you have any cases in your mind that stand out? Like as your, that was my, like I always think about that, or that's why I do this kind of thing.
It's the patient that gets better quickly. It's that sort of, this is America. We care about instant gratification, and in this field, you can get there. You can get there, and we have a lot of patients like that. Okay. We see a lot of patients, and we treat a lot of patients, and so. Yeah.
What advice would you give to somebody wanting to go into pain management?
I think that you really have to be invested in making the patient better and very interested in getting as much pain relief as possible as a personal mission. If you're not invested in it, I don't think it's for you. I think you have to be personable, and there's a technical component that has to be there. Work hard. Get some experience working with a pain management doctor or neurologist and see if it's for you.
So it sounds like you would do it again.
I'd 100% do it again, yes.
Awesome. So outside of medicine, which I'm sure is a big part of your life, what else do you do? What keeps you happy?
Yeah, I'm very much into fitness. I go to the gym a lot. I try to keep healthy. I'm a runner, although my running days are limited at this point. Keep up with friends, TV, video games. I mean, there's not a lot of time at this point for that kind of thing, but you try to make time here and there.
Well, it sounds fun. Eric, thank you. It's been a pleasure having you here. Any other questions you have, Jay?
No, I think that's
Awesome.
great. We could be here for all day. It's a very interesting topic,
Very
and it means a lot to the patients.
Very fascinating. Well, thank you, and I'm sure we're going to have you here again because folks are going to be requesting and asking questions. But yeah, it's been a pleasure. Thank you.
Thanks, Kimon. Have a good rest of the day here. Appreciate being on here.
Absolutely. Thank you for
Jason.
coming. It was a pleasure.
Thank you. All right, guys. Thank you. I hope you enjoyed this video. Please like and subscribe to our channel, and we'll catch up again in another video. Thank you.